Thank you. So, good evening, everybody. I would like to welcome our esteemed faculty, our distinguished speakers, and all our dear colleagues who are attending this webinar. So, on behalf of Oxy, it gives me immense pleasure to welcome you all to today's webinar on bridging diagnostic and the disease biology. This is being organized by the Endometriosis Committee of Oxy, an initiative which has really been, doing a great job in this year under the leadership of our president, Dr. Dhanalakshmi Madam. So, as you all know, we are conducting monthly webinars and we are looking at topics which are not being addressed in general CMEs or conferences. So, we are looking at even the basic topics which are very, very essential. So, medicine, as we all know, has entered an era where diagnosis is no longer limited to identifying the disease. It is about understanding the biology that drives it. So, as clinicians, we often see the manifestation of the diseases only. But to truly improve the outcome, we must really dwell into the molecular and the genetic aspect of the disease and also the immunological and the pathophysiological aspect of the disease. So, that is the reason why we are looking at all these topics which are generally not discussed much. So now the bridge between these diagnostic and the disease biology is where the innovation is happening. And we are also having many biomarkers which are also coming. The microRNA, which is also there in the pipeline, is all because of these understanding of biology of the endometriosis. So today's webinar promises to bring together these scientific insights and also the clinical relevances, thereby helping us connect with what happens in the laboratory and also with what happens in our clinics and operation theater. So I extend my sincere gratitude to all our speakers for sharing their experience and to all the participants who have joined us in this webinar. With that, I welcome all of you and we look forward for a very enriching and intellectually stimulating session in this webinar. So over to Dr. Priyadarshini, the MC for this particular webinar.
Thank you, ma'am. Thank you for the warm words. This is our endometriosis team.
Yeah, so
these are the discussions we are going to looking forward.
Yeah, next slide.
And
yeah,
prayer.
Slide is not moving. Yeah.
Over to you, ma'am, Dr. Sunita, ma'am.
Yeah.
Good evening, everybody. And I'm going to play the Oxy prayer. So thank you, God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom newborn. The courage to deal with it all when things are not perfect, and to remember that we are but messengers. To keep our women safe and free from sorrow, we bow before your kindness and the magnanimity of your endless love. So now I'll invite our chairpersons, Santi Gunasingh madam, and this please. So everybody knows, I don't think Santi madam need any introduction. So she's a great teacher, a great academician, and I invite her for the next.
Next slide, please. Can you share the slide?
Next.
Okay.
Let's see my slide.
Yeah. Okay. Play it. Yeah. Okay. I think we can skip all of this and just go to that.
So now Madam is a consultant in Mangalam Healthcare Chennai. She is a past president of Oxy Chennai Menopause Society and Women's Doctor Association. She is a former director of IOG and former HOD of Kilpauk Medical College. So she has lot of laurels to her yet. And now I request Madam, and then I invite Dr. Usha Vishwanath, who is the ex-HOD of Ramchandra Medical College. And now currently Madam is next CV please, Priyadarshini.
Yes, ma'am, I changed, ma'am.
Yeah.
Yes.
Yeah. So Madam now she is a professor at Muthukumaran Medical College and she was the former HOD at Ramchandra Medical College. And now I invite both Santi Madam and Usha Vishwanath Madam to share the next, the first talk, which is to be done by Dr. Kirtana. So over to you, ma'am.
Yes, ma'am. One and all. And it's really nice to see the great work being done by the Endometriosis Committee of Oxy. Right from you have been dissecting the basics well so that we become more stronger and stronger to understand the intricate problems. So the topic for today is from detection with diagnostic modalities to mapping disease extent, which is very, very important since we are sometimes caught unawares with deep infiltrating endometriosis too. So to talk on that, we have Dr. Kirtana Ashwin. Can you post a CV, please?
Yeah.
Ma'am, it is there.
Are you able to see my slide, ma'am?
Yeah,
I've
yeah.
already posted it, ma'am.
Yes, it is there.
Position specialist and lab surgeon, clinical director, Dia Fertility and Maternity Center, OMR. And she's a life member of Oxy and a patron member of PCOS Society of India. And the areas of clinical expertise being fertility enhancing lab procedures and advanced laparoscopic techniques, and has got the best paper presentation at FEM International Conference, best video presentation at Endomyoma Conference 2025. So Dr. Kirtana Ashwin, please, for her talk.
Thank you, ma'am, for the kind introduction. Can I start? Can I share, Priya?
Yeah, you can share.
Before you start, I have to say, Kirtana, you're our own girl from SRMC, which you have put there. Welcome to the forum.
Thank you so much, ma'am. Actually, I did my UG from Stanley, PG from Ramchandra. I think that's cut out of the CV. I think they've modified for Oxy slide, ma'am. Thank you, ma'am, for highlighting. Before I begin, I would like to sincerely thank all my mentors and teachers present here today. It is truly an honor to be present in front of the people who really guided and shaped my journey during my college. Thank you for being here, ma'am. With your permission, I'm beginning the presentation. Priya, are you able to see me?
Yeah, we are able to.
Okay. So now my topic today is from detection of endometriosis to disease mapping, modern diagnostic approaches in endometriosis. I'm Dr. Kirtana Ashwin. Now, the clinical dilemma that all of us face at the OPD every day is a 31-year-old female presenting with severe dysmenorrhea, and infertility. All her previous ultrasound reports were normal. Now, how do we proceed? Are we going to directly take her up for an infertility procedure, IVF, or are we going to repeat her routine imaging? Are we going to give her empiric medical therapy, or are we going to do a diagnostic laparoscopy? I'm sure by end of this presentation, this clinical dilemma will definitely be solved. Next, before we dive into this disease, what we need to know is the systemic diagnostic failure in endometriosis. As in previous presentations and webinars in the past 2 months, we've seen that endometriosis is a molecular disease. From symptom onset to diagnosis, the average diagnostic delay is from 7 to 12 years. So the fundamental challenge here is no longer just disease awareness. The breakdown occurs due to a systemic failure of structured evaluation and precise disease mapping. Now, what has changed? The diagnostic shift. Traditionally, the approach was the patient comes in with symptoms and we decide for a diagnostic laparoscopy. We keep saying it is the gold standard for endometriosis. Now, what's the modern approach that we see here is that now patient comes in with symptoms, we do a targeted imaging, we map the disease, and we tailor the treatment. Now, starting with the symptoms. A patient providing symptoms provide us a lot of anatomical coordinates. Considering the patient comes with a deep dyspareunia, there could be an ovarian endometrioma. She comes with cyclical dysuria, there could be a bladder nodule obliterating the uterovaginal space. And then there could be a dysgesia where there could be a bowel endometriosis and a shoulder pain that could map to a thoracic disease. So general presentation also includes chronic pelvic pain, severe dysmenorrhea, infertility, fatigue, and low backache. Next comes the physical examination, the physical examination checkpoint. The first thing that we see here is a posterior fornix tenderness, a fixed retroverted uterus, a palpable nodularity, and a reduced pelvic organ mobility. What is the clinical limitation here? A clinically normal physical examination always does not exclude the presence of severe disease. The blind spot of routine ultrasound. Next, when a patient comes in with symptom, most obstetricians, we now have a ultrasound machine in our consultation rooms. And the minute we do a routine ultrasound, what happens? Superficial peritoneal implants are almost 70 to 80% missed in routine 2D ultrasound, while stage 1 and 2 endometriosis, such as fimbrial adhesions, are also 50 to 60% missed in routine ultrasounds. When it comes to deep infiltrating endometriosis, 50 to 60% of them are missed in routine 2D ultrasound, and surrounding structures are not actively checked. The exception being only the endometriomas, that is the ovarian endometriosis, which has a 90% sensitivity. This is detected due to their characteristic appearance in the ultrasound. The root cause, paucity of specialized knowledge, paucity of time, no one has the time to do the ultrasound, and the criteria to diagnose deep infiltrating endometriosis. Next one, why routine fails? What's the difference between a static ultrasound and a dynamic ultrasound? When it comes to a static ultrasound, how do we have to do it? We start with the anterior compartment. We check for bladder adhesions, uterus abdominal wall adhesions. Then we go to the central compartment where there's adenomyosis, endometrioma, any hydrosalpinx is present. And then we go to the posterior compartment where there could be a bowel nodule, positioning of ovaries in POD, and kissing ovaries. When it comes to a dynamic ultrasound, there we see an anterior sliding sign, that is the bladder with the uterus, the sliding sign of the ovaries over the uterus and pelvic side wall, posterior sliding sign of the bowel loops over the uterus, and site-specific probe tenderness. Now, this is the ISWOG guidelines, the Ultrasound and Obstetrics in Gynecology has said, do a stepwise examination when it comes to endometriosis. Step 1, routine evaluation of uterus and adnexa. Then step 2 will be evaluation of soft markers. When you put the probe, is the patient having any tenderness? Step 3, assess the assessment of pouch of Douglas using real-time ultrasound based on the sliding sign. And step 4 will be assessment of deep infiltrating endometriosis in anterior and posterior compartments. This is a video showing how a sliding sign is usually performed. The probe is placed inside the vagina, anterior compartment, posterior compartment, the bowel sliding over the uterus, the ovary sliding over the uterus, all of it is checked in the dynamic ultrasound. I do have a 10-second video. Now, in the posterior uterine fundus, this is how a sliding sign is checked. Then the rectocervix is checked. Behind the cervix, the retrocervix is checked for sliding sign. And then the assessment of sliding sign in a retroverted uterus. When it's a retroverted uterus, the posterior uterine fundus is seen sliding over the bowel here. It's beautiful. It's a positive sliding sign. Next come the anterior lower uterine segment, beautifully sliding over the uterus. And then the assessment of deep infiltrating endometriotic nodules in the bladder base. Wherein here we could see that there is a bladder nodule present in front of the uterus. So now again, re-emphasizing, a positive sliding sign is always positive for the patient. A negative sliding sign may say that there are adhesions in the particular region of sliding sign being performed. Now, the sliding sign, a normal is a free sliding sign. When it comes to an endometriosis, there could be a bridging nodule that could not let the uterus move freely over the bowel, and there could be severe adhesions due to fixed organs. Predictive power of these sliding signs is pouch of Douglas obliteration, organ fixation, and anticipated surgical difficulty. Next comes the MRI. When is MRI used? When it's best utilized for when there's a bowel disease, bladder disease, ureteric involvement, and complex DIE and preoperative surgical planning. What are the critical questions that an MRI answers? How deep does this infiltration go? How extensive is the disease footprint? Which anatomical compartments are breached? Will this require multidisciplinary surgical teams? Now, comparing the TVS with the MRI, a TVS is dynamic and interactive. It is always the first line and forms the baseline mapping, highly operator dependent. No expert TVS can equal to an MRI in many DIE cases. When it comes to an MRI, it's static and deep structural mapping, independent of physical tenderness, adds critical value in complex multi-compartment anatomy. These are not competitors, they are complementary tools designed to build a complete architectural picture. Now, as surgeons, we need to remember we do not operate on symptoms. We always operate on maps. The complete disease mapping checklist that we need to remember is, are the ovaries involved? Are there uterosacrals are involved? Is the rectovaginal septum okay? Is the rectosigmoid okay? Is the bladder okay? Are there any additions? And then classify them based on the NZN and the EFI. Rethinking the role of laparoscopy. What happened before? Historically, the gold standard was laparoscopy. Now, what has changed in modern clinical practice? It increasingly relies on image-based presumptive diagnosis, enabling early treatment initiation without mandatory immediate surgery. Why mapping changes the surgical approach? It predicts intraoperative complexity, identifies the need for bowel, urology, or multidisciplinary support, enables accurate patient counseling, and allows for precise surgical planning. Now, target intervention protocols. When surgery is indicated is when there is severe symptoms, there's failed medical therapy, there's presence of endometriomas, there's DIE and infertility combined with anatomical distortion. But what we surgeons encounter during practice, during a routine laparoscopy is we see powder burn lesions, we see clear vesicles and deep infiltrating nodules, which leads to dense fibrosis and complex adhesions. Now, implications on fertility, mapping intervention point. When there's an ovarian reserve affected with endometriosis, there's a direct compromise from disease or surgical excision. There's anatomical distortion where there's tubo-ovarian structural disruption preventing natural transport. There's implantation effects when there's inflammatory pelvic environment impacting embryonic success. And IVF planning, mapping dictates stimulation protocols and pre-retrieval interventions. The pitfall dashboard. Common diagnostic mistakes. Assuming a normal routine ultrasound equates to no disease is definitely wrong. Proceeding directly to IVF protocols without prior anatomical mapping is also wrong. Where does the future take us? It is heading towards an AI-assisted imaging analysis, global standardized TVS protocols, emerging microRNA biomarkers, and advanced MRI descriptive lexicons. I end here with saying detect early, map completely, and treat precisely. Thank you, ma'am.
So,
Thank you, Dr. Kirtana. I think it's equally challenging whether to diagnose or treat. Both diagnosing and treating the entire extent is equally challenging. Nicely done.
Thank you, ma'am.
So that was a very excellent presentation, Dr. Kirtana, and your slides were too good.
Thank you, ma'am.
So very nicely you have summed up the whole thing, like how early intervention can be done if you are able to have a proper diagnosis. So the modalities and the science is really advancing, and we are able to now utilize that technology for early diagnosis. That is what is a crux. And the microRNA, of course, which is in the pipeline, is though it is found to be quite expensive, that is the only modality I think as of now we can depend on for early diagnosis. So a few of the companies have really now come forward with microRNA, and also there is a trial also happening for early detection. So as we all know, the most important thing in endometriosis treatment is how early we diagnose the disease and treat it. Because if we identify the disease at a later stage, then it becomes a real problematic situation for the patient. So to diagnose early, what are the modalities we can think about is what is the main crux of the entire endometriosis protocol. So microRNA is one of the most important thing which we all are relying upon, so that we are able to pick up the endometriosis at the superficial stage itself. itself, that is in the superficial peritoneal endometriosis stage itself, so that we will be able to, reduce the disease burden at that point only. So, and of course, the earlier diagnostic laparoscopy was considered as a gold standard, but now all the guidelines are against it because it is an invasive procedure. We have other modalities which are able to pick up this disease and stage them very beautifully. We don't have to rely on an invasive modality to diagnose and also stage the disease. So that is why once you are doing a laparoscopy, you should be proficient enough to make sure that you are able to tackle the disease by excising all the lesions. It should be the one surgery should be the best surgery and the only surgery for the patient. So that is the reason why we are now the laparoscopy as a diagnostic modality for endometriosis has taken a back step. And of course,
I think-
MRI is found to be very, very effective for diagnosing the stage of the disease. But only thing is, we need to give a heads up to all the MRI people, that is a radiologist who are screening these patients, because so how they do the MRI is also very, very important. So if you want to really identify the deep infiltrating endometriosis, it is mandatory that we need to put some amount of gel in the vagina and the rectum to demarcate the lesions so that we are able to stage them properly, and we are able to plan the surgery appropriately with multidisciplinary team. So these various modalities has really helped us to, as I said earlier, also to bridge the gap between the disease and our treatment. So you have you have highlighted all these points very beautifully, and thank you so much for the
I
excellent.
think, Dr. Mala, I just would like to add, I think we should
Madam.
also remember another promising area is AI assisted, which I think Dr. Kirtana mentioned, because we
Yeah.
never know what will come out of AI in assisting in both imaging and otherwise.
Yeah, very true, madam. So AI is actually capturing all the data now. So it will also maybe be helpful for us, once it comes out with something, so that the moment you put the probe, you will know what stage and what kind of a treatment we have to offer these patients.
Yeah, because many times the patient symptoms and the disease both they never go along with each other. Sometimes symptoms will be severe, and sometimes there is no symptoms. And it will once you do previously you used to like all laparoscopy or MRI, it will be a deep endometriosis, very severe endometriosis. That also you have to take care.
Yeah, I totally agree to that point, because many cases we have seen where the patient will be having deep infiltrating endometriosis and she's very comfortable.
Yes.
It was just picked up only during a routine checkup. But there are cases where, they have just very superficial endometriosis and she'll be really suffering in agony. So it all depends like how much of the involvement of the tissues affecting the nerve bundles and all those things matters, and the pain tolerance also. And obviously there is something called the central sensitization and peripheral sensitization and all those things which is also happening, which also we need to understand to know why some women react more and some do not react at all. So
Thank you, ma'am.
yeah.
We'll move on to our
I would
second.
like to thank our chairpersons, Shanti Gunasingh Madam and Dr. Usha Vishwanath Madam for chairing this session. And also thank you, Dr. Kirtana, for the wonderful presentation.
Thank you, ma'am.
Thank you.
We'll move on to our second scientific session chaired by Dr. Vijayalakshmi ma'am and Dr. Pallavi ma'am. I would like to invite Dr. Malaraj ma'am to introduce Dr. Vijayalakshmi Sheshadri ma'am and Dr. Pallavi ma'am.
Yeah, so Dr. Vijayalakshmi Sheshadri Madam is a multifaceted personality. She is not only academically sound, she is also very a sports enthusiast, gold medalist in swimming. So she is someone whom we all look up to, because the amount of multitasking which she does is really phenomenal. She makes sure that she does everything, and it will be to perfection. So Madam was the past president of Oxy, and she is a senior consultant in Sundaram Medical Foundation, and her area of interest is mainly high risk obstetrics, midlife health, and also recently she has done the medical law and ethics, and also she has a flair for it. So we like to invite Dr. Vijayalakshmi Sheshadri Madam for this webinar to chair the next session. Dr. Sunita, should I introduce or how?
Yes,
I'll
ma'am, you
do.
can.
That's okay. Okay, ma'am, you do.
Okay, so I'd like to also invite Dr. Pallavi, Madam, who is a professor of Mahatma Gandhi Medical College and Research Institute, Pondicherry. And she has a teaching experience of about 19 years for both the undergraduates and the postgraduates, and has more than 50 national and international publications, and has authored various chapters in the UG and the PG textbook. And it is an honor and privilege to have you with us.
Thank you, ma'am.
Can Panaga Madam please kindly mute? Yeah,
Yeah.
request all our delegates to keep muted. Yeah.
Sorry, ma.
Kanagu, please.
Please.
Yourself. So thank you very much, Mala, for that beautiful introduction. I would love to have you as a computer for all my programs so that I keep this. Thank you very much, Priyadarshini, for
Thank you, ma'am.
coordinating with us. And of
Thank
course, thank you, Sunita, for reminding me all the time. So thank you, Endometriosis Committee of Oxy. Now, we have a very interesting topic as progesterone resistance, decoding it as a key to understanding endometriosis. I love this topic because it also made me know that, yes, all the places where there could be an estrogen dominance or an estrogen dependence, those states can face this progesterone challenge, progesterone resistance, and then they can pose a challenge to the management of that particular problem. I suppose what you are saying, I will be hearing to Dr. Sharanya, but I think after that, I might even think this might be the same condition for even uterine endometrial carcinoma and all other issues where it is estrogen dependent. Anyway, going on to Dr. Sharanya Jilumudi. She is a joint director of the Lalita Ambike Fertility Center at Lalita Ambike Medical College and Hospital, Chennai, and is also a consultant gynecologist and laparoscopic surgeon at Lifeline Hospitals. She has lots of achievements to her credit, and Dr. Pagdala Rajaram Gold Medal in MS Obstetrics and Gynecology. I suppose a very young graduate, and therefore should have more years to add on to even a bigger list of your CV. So over to you, Dr. Sharanya, and after your talk, maybe we will have some more questions to ask.
That's a wonderful introduction, ma'am. Yes, ma'am, I have a long way to go. Can I start sharing my screen, Dr. Priya?
Yes, Sharanya. Yeah, I have. You can share your screen.
Can you see my screen?
Yes.
So, good evening, everyone. I would like to thank Oxy Endometriosis Committee for giving me this opportunity and for giving me such an interesting topic. Today, we'll be seeing about this topic, decoding progesterone resistance, the key to understanding endometriosis. So, just the introduction to what is
Can
endometriosis.
you minimize my face?
Oh, how do I do that? Okay, yeah.
Thank you.
Yeah. So sorry, just a second. Yeah. So we all know endometriosis is a chronic estrogen-dependent inflammatory disease where the endometrial lining grows outside the uterus. It affects about 10% of reproductive aged women. And like Dr. Keetana was saying, there's almost a 7 to 10 year average diagnostic delay. And in India alone, there are about 26 million women who are affected by this disease. And what we know is that this disease where the lesions grow under the effect of the estrogen stimulation. So what are the key symptoms? They have chronic pelvic pain, dysmenorrhea, painful intercourse and dyspareunia, infertility, anxiety, depression, and reduced quality of life. And majorly 3 subtypes, which is superficial peritoneal, ovarian endometrioma, or deep infiltrating. endometriosis is the three types. And we also see that there's almost a 10.8 hours work productivity lost per week due to the debilitating condition of endometriosis. So what is the current treatment strategy? So now current treatment landscape that is available is that surgical method where we can go for a minimally invasive approach is preferred. You remove the and you can also choose for a hormonal therapy where the first line is like if you go for progesterone combination or only a progesterone only hormonal therapy, which we use Diagnostics for long periods now. And also the novel GnRH agonists and oral GnRH antagonists can be used. Some of the other drugs that are available are the selective estrogen receptor modulators, progesterone receptor modulators. But why are progesterones generally preferred as treatment is that they have an anti-estrogenic method where they suppress the estrogen that fuels the lesion growth. They have an anti-inflammatory effect which reduces the interleukin 6, interleukin 8, TNF alpha, and they also boost the natural killer cell activity. VEGF-driven blood vessel formation, and they're a pro-apoptic. They have a pro-apoptic activity where it induces lesion cell death. It inhibits the matrix metalloproteinesis. So when we have a perfect solution to the problem, what happened? So suddenly there is a plot twist ahead. So what happened is that the core problem was a progesterone resistance. So what is the difference? We define it as the endometrial inability to respond normally to progesterone due to the dysregulation of signaling pathways and gene networks. It is found that 1 in 3 women with endometriosis do not respond to progesterone therapy. So the real-world evidence shows improvement even after 28 week Diagnostics treatment, and 23% had no effect at all in 3,000 patient prospective. 15.3 patients failed their treatment after 24 months. So where does the resistance occur? They occur usually in the ectopic endometriotic lesions and also in the utopic endometrium of affected women. And it persists even in well-controlled lab cultures. So the key concept here is that resistance is intrinsic to the tissue and not just low circulating progesterone levels or because of a progesterone deficiency. So before we dive into
1 second, Sharanya, can you improve your audio? I mean, the quality of
volume,
your... Yeah, it's not.
Can you hear me now, ma'am? Can you hear me now?
You come closer to this and don't keep moving. I don't know, in expression, maybe you are moving. I can't see your photo. But many are also putting in the chat that the voice is not clear.
Your voice is breaking, actually.
Sharanya, just a suggestion. Can you remove the earpods and speak? So it will be clear through the laptop. I think the earpods are filtering the volume.
Or maybe she's with her phone or she's moving or what. Everybody, I mean, many chats have come. So just check on if you can improve the quality.
Sharanya, are you there?
Sharanya?
I think she's hooking on to some other device, maybe.
Yeah, I'm just, yeah.
No.
Sharanya,
Yes,
you're muted. Sharanya, unmute yourself.
You're muted. You unmute yourself.
No. Sharanya, we can't hear you. Unmute yourself. Sharanya, unmute.
Just a second, ma'am. I am unmuting, ma'am.
No. We can't hear you. Please unmute.
Can you hear me now, ma'am?
Yes. Please come close to the laptop and then talk.
Am I audible now, ma'am?
Yeah, much better.
You have to
Yes,
share
ma'am.
your screen again.
Yeah,
Sharanya.
I'm just Yeah, so moving on to how, before we understand what the progesterone resistance is, am I audible now?
Yeah, but then go on slide mode.
Yes, ma'am. So how does progesterone work? So the physiological role of progesterone is that it suppresses endometrial proliferation. It drives secretory phase transition, that is, it helps in decellularization. It supports embryo implantation and pregnancy, and helps in uterine growth and mammary gland development. So before we understand progesterone resistance, we need to understand there are two types of progesterone receptors the progesterone receptor A and the progesterone receptor B. The progesterone receptor A and B balance is the critical switch that happens in endometriosis. The progesterone receptor B is a strong transcriptional activator. It activates progesterone signaling, and if it has to be dominant for in normal conditions. Whereas progesterone A is a weak activator and it represses the progesterone B.
No.
Hello, ma'am, can you hear me?
Yeah, go ahead. Yeah.
So the progesterone receptor A, it represses the progesterone B function, and if it is dominant, there is increased resistance. In endometriosis, the progesterone B receptor is lost or reduced. Progesterone receptor A becomes dominant, which causes a reduced progesterone response. So the ratio is, the progesterone A to B ratio is increased, and there will be a progesterone increased resistance. So to understand the receptors, you need to understand there are signaling pathways. There is a genomic and a non-genomic effect. In the genomic pathway, there is a ligand binding that happens, and then it moves to the nucleus and it causes the genomic effect. Or there are also a second messenger signaling pathway, the CCAM pathway, the calcium pathway, which have their physiological function. So normal progesterone receptor physiology, we have a 5-step progesterone signaling cascade. First, the ligand binding happens, then the dimerization happens, where the activated progesterone receptor forms progesterone receptor B, homodimers, and coactivated recruitment happens. And then there is chromatin remodeling, which helps in the activating of the chromatin and which increases the HOXA10, HAN2, FOXO gene, and insulin receptor binding protein. These all helps in improving these things, which will help in the progesterone receptor activity. And then there is a target gene activation, the deserialization program, which happens over the 48 to 72 hours, in which there should be increased HOXA10 genes, HAN2 genes, FOXO genes, and insulin growth factor binding protein, increased prolactin should be there. But in progesterone resistance, all these signaling cascades are reduced because of the loss of the progesterone receptor B function. So the PRA isoform, if it is dominant, there will be a transcriptional repressor, and reduced progesterone B isoform will not be active. So the progesterone B isoform, which is a transcriptional activator, needs to be intact and active for a proper deserialization and proper physiological progesterone activity to occur. So what is the evidence for progesterone resistance? There can either be a receptor loss where the progesterone B is absent or reduced. Patients with lower progesterone receptors fail progesterone therapy, and PRA becomes the more dominant isoform. There can be dysregulated target genes like your FOXO1A, HOXA10, and your the genes are downregulated, and proliferative genes are failed to repress. So the proliferative genes like Ki67 will be increased. The same pattern can also be in controlled lung culture. And the protein levels, the end protein levels like glycodelin and osteopontin, and the IHH and the pathway which is needed for deserialization is disrupted. So which leads to the impact deserialization. The normal fibroblasts fail to deserialize, and the insulin-like growth factor B protein 1, there is a reduced quantity of that, which strongly suggests an intrinsic progesterone signaling defect. So what are the mechanisms of progesterone resistance? There are 5 key mechanisms: progesterone deficiency, decreased progesterone receptor activity, dysregulated gene networks, disturbed gene receptor signaling, and mesenchymal stem cells. We will be looking into each of it detailedly. So in progesterone deficiency, there are 6 different pathways which suppresses the progesterone B receptors. The excess estrogen receptor beta. If there is an estrogen receptor beta overexpression, it suppresses the estrogen receptor A, which normally drives the progesterone receptor production. So we also have to understand that the right estrogen receptor is also important for the proper functioning of a progesterone. So the net result will be a reduced progesterone receptor expression, even if there is an excess beta estrogen receptor. Then we move on to DNA hypermethylation, which is your epigenetics, and the DNA hypermethylation causes the PRB promoter is hypermethylated. It silences the transcription epigenetically. And then chronic inflammation, microRNAs, environmental toxins, and gene mutations. We'll be seeing about each of this in detail. So quantitative PRB loss is in endometriotic lesions. The B isoform is severely depleted. PRA dominance blocks any residual progesterone signaling. Result is an estrogen dominance goes unchecked, and molecular fluid for lesion survival and proliferation. the epigenetic silencing is very important. So basically, what is epigenetic mechanisms? These are reversible genetic modifications that occur due to your development in utero development or environmental chemicals, drugs or pharmaceuticals, aging, and even your diet can modify these genetics. That's why they call epigenetics. And the end result will be they can cause cancer, autoimmune disease, mental disorders, and diabetes and endometriosis. So the genes that should respond to progesterones are locked via DNA hypermethylations. The HOXA10 gene, HOXA11 gene, which is essential for deserialization, that's found silenced in ectopic tissue. There is overexpression of DNA methyltransferases, which causes higher levels of DNA methyltransferases, and PRB promoter methylation also. It is repressed epigenetically. There is an inflammatory loop which is important for the disease progression. There is a tumor necrosis B activation, which leads to COX2 overexpression, increased prostaglandin productions, which reduces the progesterone receptor downregulation. There is loss of an anti-inflammatory action and more inflammation. This creates a self-sustaining environment where medical progesterones fail to find enough receptors to break the cycle. So basically, inflammation is both the cause and the consequence of the death. Then we move on to the microRNA dysregulation, which is very, very important now in our understanding of endometriosis. The microRNAs act as molecular scavengers, degrading the progesterone receptor messenger RNA before it can be translated into protein. So the microRNA 29C196B are the target progesterone mRNA for degradation. And now we found that the microRNA 135 is more increased in Indian patients, which will cause their endometriosis disease progression. So now there are targeted therapies in which we need to find to look for microRNA, which correlates with the lower HOXA10 expression and implantation failure. So now the therapies and future things are looking at mRNA regulation. So moving on to environmental toxins, exposure to dioxins are persistent endocrine disruptors found in industrial emissions and in your perfumes and all that. They activate a pathway called the aryl hydrocarbon receptor pathway, which will lead to altered gene expression, decreased progesterone receptor expression, and disrupted signaling, which will lead to progesterone resistance and endometriosis progression. And also your epithelial mesenchymal transition and gene mutations. So normally, epithelial endometrial cells has high progesterone receptor expression. When there is an epithelial mesenchymal transition and gene mutation that happens, there will be a resistance to your progesterone gene receptor. And also genetic mutations that are commonly seen is the ARID1A gene, like how Vijayalakshmi was just mentioning that these are the genes that will cause even the endometriosis-associated ovarian cancers. This ARID1A gene is mostly the gene that is affected in your endometriosis-associated ovarian cancer. And obviously the PTEN and the class gene mutations also, they alter key pathways and progesterone receptor signaling, which will lead to your endometriosis disease progression. So there are other mechanisms like decreased progesterone receptor activity, where you have your progesterone receptor polymorphisms, in which there are incomplete phosphorylation leading to impaired progesterone receptor activity. And there are the FKB, P5, and HIX5 chaperone proteins, which are disrupted by inflammatory cytokines. There is compromised CCAMP pathway, impaired progesterone receptor functional activity. And you're having your dysregulated gene networks. All these pathways and gene networks are future targeted therapies where we can reverse the progesterone receptor resistance. So you have your HIPPO-YAP1 pathway activated in endometriosis, again leading to an microRNA disruption and decreased progesterone receptor activity. So blocking your YAP1 pathway using a drug called verteporfin, which can restore your progesterone receptor and reduce lesions without harming fertility, is under study. And there's another pathway, the phosphorin kinase K pathway and AKT pathway, in which if they're overactive, you have your progesterone receptor activity to be reduced. And HOXA10 promoter hypermethylation reduced endometrial receptors. There can also be disturbed PGR progesterone receptor signaling, where like I previously mentioned, the IHH FT2WNT pathway is disrupted, which is an important pathway needed for your deserialization. And the tumor growth factor pathway signaling also leads to PRB signal protein deficiency, leading to endometrial non-receptivity. And then there's another important mechanism called the mesenchymal stem cells inherited resistance. the stem cell connection to endometriosis. There is studies that believe that endometrial stem cell, mesenchymal stem cells are progenitors of stromal fibroblasts. In women with endometriosis, these endometrial mesenchymal stem cells are defectively programmed. These fail to decidualize in response to hormone treatment, and stromal fibroblasts derived from these endometriosis mesenchymal stem cells also fail to decidualize. And there have been initial studies which show that metformin can correct these dysregulated genes and mRNAs in faulty endometrial mesenchymal stem cells, restoring normal differentiation, a promising reversal strategy. So the key implication is that progesterone resistance may be inherited from a defectively programmed stem cell, making it an intrinsic pre-programmed property of the tissue, not just an acquired response to the disease environment. So the therapeutic angle of this is that the targeting the stem cell population or reversing epigenetic misprogramming may overcome resistance at its root. So what are the emerging therapies and future directions? So we have biomarkers and precision medicine approach. So we need to stratify patients based by their progesterone resistance phenotype. We can use tissue biomarkers like your PRB and PRA ratio, Hoxaten expression, HAN2 immunostaining, and SRC2 protein levels. You can also look for fluid, peritoneal fluid, interleukin tumor necrosis factor, serum CA125, which is a non-specific one, extracellular mRNA panel, which is investigational, and circulating VEGF-A levels. Genomic, epigenomic things that we can check are the progesterone receptor promoter methylation for biopsy, your ARIDA1 mutation status to check for endometriosis-associated ovarian cancers, again your microRNA levels, and your liquid biopsy research is there, or DNA methyl liquid biopsy is there, and functional tests such as in vitro decidualization response to medroxyprogesterone assay, primary cell progesterone sensitivity assay, and organoid-based drug response. They're all future things that are under study. So emerging therapeutic strategies, selective progesterone receptor modulators, mifepristone is under study to reduce in cases of dysmenorrhea reduction. Newer agents are asopressnil, uripristol, and vilapristone. Vilapristone has good tolerability and minimal liver toxicity compared to uripristol. We also have your SERMs, targeted estrogen receptors selectively. There is raloxifene, which causes lesion regression in animal models, but we need to use them with caution as it may shorten your relapse time. And now we are widely using the GnRH antagonists, which oral formulations are available. These reduce the estrogen levels. So irrespective of the progesterone resistance or not, this can be used. And they also have their effect is reversed rapidly after stopping the medication. So molecular targets in development are your mRNA antigomers, which block the mRNA and restore your progesterone receptor expression. Pathway inhibitors like your YAP1 inhibitor, verteporfin, or AKT inhibitors are under study. Demethylating agents, which can reverse the progesterone B promoter hypermethylation, and metformin for your faulty mesenchymal stem cell programming. Cannabinoids are under study to reduce, they are found to reduce lesion volume in mouse models. So emerging pipeline targeting therapy is your EZH2 inhibitors, which is a tazimetostat. They have mechanism in the genetic signaling pathways can be changed, and these are all under study. And then you also have the DNA methyl transferase inhibitors, your decitabine and your azacitidine can be used. And selective estrogen receptor B antagonists, which will increase your estrogen receptor A expression and in turn increase your progesterone receptor expression, are also on the study. So key takeaways is that 1 in 3 endometriosis patients fail progesterone therapy. Progesterone resistance is a major unmet clinical need. Progesterone resistance is a core molecular feature of endometriosis, not merely a therapeutic side effect. The progesterone receptor B deficiency is the central driver. It is suppressed by inflammation, DNA hypermethylation, microRNAs, environmental toxins, and aberrant signaling. Resistance is intrinsic to the tissue, not just low circulating progesterone levels, suggesting the need for targeted molecular interventions. And multiple overlaying pathways are noted to converge on the progesterone receptor suppression. So novel therapies under study, which they offer hope in reversing the resistance at stem cell level, is a frontier goal. So in conclusion, endometriosis is not simply an estrogen excess. It is fundamentally a progesterone resistant state. So understanding progesterone resistance is the key to overcoming treatment failure and improving outcomes for women with endometriosis. Thank you.
Dr. Saranya, that was an excellent talk, and you have very well detailed the molecular mechanism for the progesterone resistance. And from today's talk, we have understood that it is not only suppressing the hormones, but instead we have to restore the body's sensitivity back to these hormones using more targeted molecular therapies. I have just one question regarding this epigenetic silencing. You said that some diets are responsible for this epigenetic silencing. Could you little bit highlight on what sort of diet?
Your highly
these are-
processed diet, monosaturated fatty acids containing diets have to be reduced. So going back to your organically grown food and pesticide-free food, highly processed and packaged foods should be curtailed.
Because we are seeing this endometriosis more commonly in adolescents, and we know that they are all used to this outside food and all.
Yes,
So
madam.
I think we need to research more on this aspect also
True,
in
madam.
future.
Doctor,
Any questions?
endometriosis and Pallavi endometriosis committee will have that in the next topic.
Yeah,
Yes.
it is there in the pipeline.
Yeah. See, it's I could understand most of it, but some, of course, is too complicated to understand in the first instance. I just want to ask, like, okay, you have lined up and you have brought it very conspicuously, saying that progesterone challenge, I mean, the resistance is there, and therefore many don't respond to the treatment by progesterone. That's
Yes.
a basic, right?
Yes.
Now, you said diagnosis and all those big tests, but day to day, do you have anything in handy where, except that the clinical scenario is that they don't respond, so you think it is not just the estrogen excess, but also an underlying progesterone resistance, which doesn't allow our management modality to act, the medical side of the management modality. So, how do we really get to know? Only by clinical sense, or I know there were many tests, but what are all
Currently, I
handy,
think
or what can be done?
for our Indian scenario, we have to take, I think, starting with the detailed clinical history taking relating to how their, including the
Again,
epigenetic.
you are not proving, you are only presuming that there is a progesterone challenge. I mean,
Yeah,
progesterone
madam.
resistance. So, do we
Madam,
have anything in hand which can tell us, yes, the
Yeah.
progesterone resistance is? Yes, Mala?
Madam, there is immunohistochemistry analysis the endometrial tissue. So there is a paper where they have taken endometrial tissue samples and done immunohistochemistry on that and found out whether it is progesterone A or the progesterone B is deficient in that particular patient. So, but the thing is, like, if you are able to understand that, then our treatment also gets a little bit simplified. So initially, like, this is something which is an ongoing trial. I mean, we are not ongoing. In fact, we are going to start a trial also along with this Satyabama Research Institute. In fact, we have just given a proposal to them to understand what would be the reason for resistance in that particular patient, whether it is A or the B receptors which is resistant in that patient, so that we can utilize only that kind of a molecule to work on that particular patient. So invariably what is happening now is we are trying them with all kind of progestins. And then finally coming to a conclusion saying that, okay, it is not working. That is the reason why all these new molecules are coming, like agonist and antagonist are all coming, because 30% of these women are resistance. They have a resistance to progesterone. That is the group of patient where the antagonists are working now. So now this particular study, we are planning to do it along with these people, genetic people, to understand which would be the factor for these women, which is causing resistance, and we are trying to work on it, madam. Maybe soon we will have an answer to that. What you are asking is a very,
Let the
very,
research go
which is
on.
very valid
Okay, day
question,
to day, I
madam.
think it will take many years to come and prove and become. I mean, patients should be able to afford also, right? So immunohistochemistry, we are at present doing for malignancies and all, or finding out the malignant cells shedding in the peritoneal fluid, where sometimes you are not able to find out the origin of the malignancy. And then by immunohistochemistry, you are able to even spot which is the tissue which is causing the malignancy. So to that level is fine. But day to day, I think to come to use Even immunohistochemistry, just to know which progesterone and all, I think will take several
It will
years.
definitely take some time, but then I
Right.
think lots of work is
It's
also
a nice food for thought. And
Yeah.
as I said, whether this is also the same case for all the estrogen dependent problems where we take, for example, endometrial hyperplasia or this where we take progesterone for the therapeutic mode. So will be the same reason where, you know, some of the endometrial hyperplasias don't respond to levonorgestrel IUD. So whether this can come on in the same way.
Yes, madam.
I
Like
can't
I
hear-
just mentioned in the study that gene mutations, madam, that ARIDA gene and crash mutations and all, they cause that endometriosis-associated cancers, hyperplasia, which are not responding to progesterone. Those gene dysregulations are cause is what some studies are saying, madam. Could be even for all the hyperestrogenic states, they can cause cancer, and how their progression can happen is justified by this same mechanism.
Yeah, because in breast malignancy, we have gone way ahead with the
Yes,
PR receptors and the estrogen receptors, and they give based on that. But whether the same applies to endometriosis or to
looks like it, madam. Looks like it. There is one
Hmm.
question in the group which is progesterone resistant or resistance only in ectopic endometrial tissue or even at the level of uterine endometrium. So if there is an intrinsic progesterone receptor deficiency, even in the uterine endometrium,
Normal
there
uterine.
can be resistance of progesterone receptors.
Yeah.
Saranya, it was a nice presentation. I think this is actually a recent advanced question for the postgraduate students.
Okay.
So the way you are presented, if some PGs would have attended, maybe PGs will be there. So they will be very much benefited by this presentation.
But
Yeah,
give this
because
paper earlier to the judge. Otherwise, we won't be able to understand
Yeah,
it.
so this is like one high funda rocket science.
Yeah. So many we don't.
she has everything compiled and nicely she has presented. So for the postgraduates, they cannot go back and read so many things. So this is actually a recent advanced paper for the postgraduate
Yes, madam, I'll
students.
be happy to share, madam.
So just to simplify, I think just to simplify Sharanya's talk,
Yeah,
only
please.
thing is like what is progesterone resistance is the reduced biological response of the endometrial tissues to progesterone. Normally, we have progesterone and estrogen doing its own thing. Progesterone's main role is anti-inflammatory. So when there is a progesterone resistance, there is no that anti-inflammatory effect of the progesterone is lost. So that is the reason why all these endometriotic tissues keep growing in spite of the progesterone being present in the tissue. So to attack these progesterones only, we have antiprogestins which are coming to play a role. And if you look at the progesterone also, as she stated, there are two receptors, A and B. The progesterone B is deficient. So as a result, A is overtaking. So the molecules are not able to act because the B receptors are deficient. And for the B receptors to work, you also need the estrogen. Little bit of the estrogen receptors A and B, for which the estrogen B is also very, very important. So in these women, if you see the estrogen B receptors also would be deficient. So this is, I think, to summarize the whole thing into a nutshell. And of course,
We all know that estrogen promotes progesterone receptors, right? And progesterones inhibit estrogen. I mean, either way. So probably we have to now differentiate between progesterone A and progesterone B receptors. So that is the basic. And you said somewhere that only metformin can protect that, right?
Yes, ma'am. There are initial studies to say that the mesenchymal stem cells that are reprogrammed can be reprogrammed by using metformin, ma'am. The studies are very, very initial stage, but there's no real clear evidence for that yet.
Yes, ma'am. They are telling now metformin, it is like a new drugs like in endometriosis. I think few studies are there, but that is not any RCT or something.
Inclusive
Few
RCT.
studies are there, yeah.
So slowly, laparoscopy, not only from diagnosis, I think even for management, you will have to change your laparoscopic interventions. Nice to hear. Very compact and good. Nice food for thought and lot of research scope is there. Thank you very much. Thanks for the opportunity, Mala. Thank you very much. Thanks, Sunita, and their whole endometriosis.
Ma'am.
Thank you.
Thank you,
Thanks,
madam. Thank
Pallavi.
you for this.
Thank,
Thank you for the
thank you
lovely
all
opportunity,
the
ma'am. Thank
society for inviting me for chairing this session. Thank you, madam.
Yeah.
Thank you, Pallavi. Thank you, Biji ma'am.
Yeah.
Thank you, Usha ma'am.
Yeah.
Usha ma'am
Thank
and
you.
Santi ma'am.
Yeah.
Hi,
So,
Usha. Nice to share this
thank you,
screen
thank you,
with
thank you so
stage
much.
with
Same here, ma'am. Same.
sharing the stage with you.
Yeah. So thank you. Excellent presentation by both Dr. Sharanya and Dr. Kirtana. And it was a very informative and in fact, as I mentioned earlier, only in these webinars we'll be able to discuss so much in depth about these topics. Otherwise, we do not get much time to discuss in a CME or in a conferences. So I think this is a very great initiative from Oxy by our president. And so we look forward for more such, informative ones. And we have another one coming up next month also. And I will also like to thank all our chairpersons, Dr. Shanti Madam, Dr. Usha Vishwanath Madam, Dr. Vijayalakshmi Sheshadri Madam, and Dr. Pallavi Madam for their valuable time and their inputs also. With this, we come to the end of the session, and I'd also like to thank Shield Pharma for providing their support with this academic platform. They have been always very, very kind and supportive. And thank you so much, Sahiti, for making sure that we run these programs seamlessly without any hitches. And also like to thank all our delegates who have attended this webinar and benefited. I think we had more than 60 delegates attending this, and I'm sure all of them would have really benefited. We'll share the YouTube link as well, so if those who have missed can also watch this, because this is a very, very informative one which would be useful in our day-to-day practice also, and for further understanding of endometriosis. And as has been mentioned here, there's quite a lot of place available for the research work in this particular specialty. And we look forward for many such things. Maybe we'll get back to you as endometriosis committee. We'll also try to work on something. And our entire endometriosis members will join together, and we will do something on this particular aspect. So I would like to thank Oxy for giving us this wonderful opportunity, and our co-chairperson, Dr. Sunita Samal, also for making sure that we run these programs excellently. Thank you so much, Dr. Sunita, for being with us, and also as an endometriosis co-chair. Thanks a lot for your valuable inputs and efforts.
So
with this,
Mala, in Oxy, you're going to run an endometriosis conference, right? Not in Oxy. That's 360 degree or something. Are you picking up these topics also there?
Yes, it's all there. So we have given all these topics to the juniors, like the
only they can do.
Madam, please, all of you attend endometriosis 360.
It will be very nice actually.
Really enjoy and benefit, because we have made sure that all aspects of endometriosis, the complete 360 degrees we have worked on. Have released a scientific brochure today only. We have made sure that we have not left any stone unturned. So I request all of you to attend endometriosis conference and benefit, because we have excellent national faculties also, not only the surgical faculty, but
do this further in Foxy also.
Yeah, we are continuing every month, madam. We are continuing.
No, Foxy, you will be going there, no? As chair.
Yeah. Do that. So I'm just waiting for the official confirmation from Foxy, madam. So maybe it will take a week's
time. All the
time.
best for that, Mal.
Thank you so much. This is my field of interest, and I want to do more work on this. So I invite you all. Do you have the flyer, Dr. Priyadarshini? Are you having the flyer in the presentation? No.
No, ma'am. I can share.
So we have multiple conferences coming up. So we have the endometriosis conference on July 4 and 5, which I request everyone to attend and benefit. We have a live surgical workshop only on endometriosis. So you can imagine the amount of work which should be happening. So please join us, and the full day of scientific session also. And then following which, we also have a mid-year conference from Oxy coming up. The theme would be only on contraception. So that is also yet another interesting one. And then we also have the menopausal conference also coming up. So the multiple things are there. Please block your dates and make sure that you get updated and also enjoy and benefit. So thank you so much. We see you all in the next webinar.
Thank
And
you.
before that, I'll
Bye.
see you all in the
Thank
conference.
you.